It's a pleasure to introduce the GI session from ASCO this year. I think we're going to have a controversial discussion, and to help us through, I've got Andy Webb, Mark Harrison and Kai-Keen Xu.
So I'm now going to summarize some of the interesting abstracts presented at the ASCO GI colorectal oral presentations. The first study was a well-conducted placebo-controlled double-blind study of giving intravenous calcium and magnesium to try and prevent oxaliplatin-induced sensory neurotoxicity. I think this was actually one of the few practice-changing trials because it showed that actually there was no difference whatsoever in reducing grade 2 neuropathy, acute and chronic, with calcium-magnesium infusions. The study also produced some very nice graphs, which we'll discuss later. But basically, this was a good study. The next two studies were discussing the role of maintenance chemotherapy. The first one was the CAIRO-3 study, and this essentially showed that the patients had 6 cycles of capox bevacizumab, and then were randomized to either observation or a capecitabine bevacizumab combination. And then on progression, they could reintroduce the first-line chemotherapy. They had interesting number of endpoints, which we'll discuss further, but their primary endpoint was progression-free survival at the second endpoint, which was this, and this was significant. However, they also showed all the other endpoints, and I think the important thing to show here is at the moment the data for the overall survival is immature, but it's a well-tolerated treatment. So the key messages are here that maintenance treatment with CAP and BEV after 6 cycles of CAPOX-B is definitely feasible, and it does prolong progression-free survival. The overall survival data is immature, but it's well tolerated, and it is certainly a treatment strategy now. The next maintenance study was from the SAC, a Swiss group that looked at maintenance bevacizumab after first-line chemotherapy combination with bevacizumab. This was an interesting non-inferiority study which looked at whether, in fact, no treatment until progression was non-inferior to bevacizumab. The primary endpoint was time to progression, and there were the standard secondary endpoints. The important thing to say about this was actually this was a negative study, that no treatment was non-inferior to continuance on bevacizumab, and for the first time we saw cost analysis as part of the results, and we'll discuss this further, but you can clearly see the substantial cost of giving maintenance bevacizumab for this group of patients. We now go on to the new EPOC study, which was a study of patients who had operable or borderline operable liver metastases. They were randomized to a control arm of chemotherapy. This was dealer's choice for 12 weeks, followed by liver resection, followed by further post-operative chemotherapy. The experimental arm added in cetuximab to the backbone of chemotherapy, again with a liver resection followed by the post-operative chemotherapy. The primary endpoint was progression-free survival, and there were the standard secondary endpoints. And these were the results, and what has to be said was this trial was stopped early by DMEC, but only after only half the events had happened. But what you can see here, interestingly, is that the patients who had had cetuximab actually fared worse and had reduced progression-free survival. And although this is immature data, there's a trend that perhaps even overall survival is worse. So what are the key messages here? The key messages are that the combination of chemotherapy and cetuximab should not be offered to patients outside the context of a clinical trial when they have operable liver disease. But clearly, further translational work is needed to try and understand the reasons why this result occurred. The next study was the TRIBE trial, where they were randomized people to a triplet combination of FOLFOXIRI and bevacizumab versus fulvery-bevacizumab. And it was a one-to-one randomization with the standard criteria. The primary endpoint here was progression-free survival, and there were the standard secondary endpoints. And this is the Kaplan-Meier curve, and this was a significant result that progression-free survival was improved on the triplet FOLFOXIRI plus bevacizumab arm. We'll discuss this later. Although the trial achieved its primary objective of superiority of the triplet combination with PFS, we'll talk about the specific side effects and also the patient population, which may be quite specific and quite a narrow indication for this combination. The next study was a head-to-head comparison of FOLFIRI plus cetuximab versus fulvery-bevacizumab in KRAS wild-type inoperable metastatic colorectal cancer. This done by the German AOI study. So as this schema shows, it was a one-to-one randomization. It was well-powered. There were almost 600 patients, and they got randomized either to FOLFIRI plus cetuximab or FOLFIRI plus bevacizumab. There were some amendments to only include wild-type KRAS. The primary objective was an interesting one, which was overall response rate, and there were some standard secondary endpoints. The important thing about the results is they actually failed their primary endpoint, and they did not show a significant overall response rate, which showed that cetuximab was superior to bevacizumab. A secondary result, which was very interesting, was the difference in median overall survival. And we'll discuss this further, but this did show there seemed to be a significant difference, an increase in overall survival if you gave the FOLFIRI cetuximab first versus the FOLFIRI bevacizumab. So FAR3 is a head-to-head comparison of FOLFIRI cetuximab versus FOLFIRI plus bevacizumab in KRAS wild-type colorectal patients, but it did not reach its primary endpoint, and there's an interesting but unexplained difference in overall survival. The last couple of abstracts which were interesting was one by Cochrane et al., and this looked at some preliminary data on some pharmacodynamic studies and efficacy of a combination of a BRAF inhibitor, that was dabrafenib, and a MEK inhibitor, trametinib, in BRAF V600E mutant patients. This was early data. It's thought-provoking, and certainly more trials and more mature data is required. Another trial which was negative, however, was the randomized placebo-controlled phase 2 study of tivantinib, which is a MET inhibitor. And although it was well balanced, this was a negative trial, and this was stopped. This shows that at this time, a MET inhibitor cannot be offered to patients outside a clinical trial. Okay, so Andy, this was the one of the first aspects we looked at. Can you comment about anything that we thought was particularly interesting?
Yeah, I mean, this was a really well-designed study. They looked at chronic toxicity, they looked at acute toxicity. They did it very, very well with very detailed recordings. And actually, the curves just look identical. I think it's clearly saying we shouldn't be using calcium magnesium to moderate neuropathy.
I completely agree with Andy. The only thing I'd add is these images, the slides of an oxaliplatin-related neuropathy, are the best graphical evidence I've ever seen of that. They show the acute event getting better, then getting worse, and the chronic event and how it comes in. So they're actually fantastic physiological proof of an oxaliplatin neuropathy.
I mean, I think the only other kind of general thing to add was when Tim Morn did Discussant, it was about the idea that in 2004 there was a hypothesis-generating trial which seemed everyone just jumped in and changed their clinical practice without the evidence. And this actually clearly shows that we shouldn't be doing this.
There is one arm that I'd have liked to have seen in this trial, which is a no placebo, no treatment arm, which is actually mainly standard practice in the UK, because that would have given you evidence of a placebo effect.
Sure.
And if there is a placebo effect for our patients, then it may be beneficial, but we'll never know that now.
Okay. So, Mark, this was the first maintenance study which was looked at. Do you want to make any particular comments about this study?
I think we're going to talk about both maintenance studies. I think this is another well-designed, well-thought-through trial. We're seeing the results of which 5 or 6 years after they designed the study. Their endpoint is interesting. PFS2 is interesting because they're basing their endpoint following the reintroduction of effectively Xelox. And the interesting thing for me, and a difficult one to do, and I agree, is actually the end of the maintenance treatment is perhaps more relevant to us than trying to give patients who've already had pretty extensive amounts of oxaliplatin further chemotherapy.
Sure. I mean, I think the thing which stands out for me in this is it's kind of what a lot of people have been doing for a while. And I think it does back it up. It doesn't quite translate through to an overall survival benefit. But there's a lot of things going on after the progression. So,
and what's your feeling of the fact that they were using a lower dose BEV and it was well tolerated? Do you think that's definitely?
I think that's largely done in practice. Actually,
Okay.
I think a lot of people play with the dose.
Yeah. The other thing is that it's worth pointing out the capecitabine dose was interesting, 65
Yeah,
milligrams
so
per square BD
yeah.
continuously, which is in general seems to be a very well tolerated way of giving capecitabine. I think what's also interesting about this is the planned de-escalation of chemotherapy. This is not treatment to progression. This is a de-escalation, removing a drug which is actually pretty toxic by the time you've got to cycle 6 of Xelox. I think that was a really good thing to see.
The patients like this,
yeah,
really like this.
And I mean, how practice changing do you think this would be in the UK?
That's the million-dollar question,
Sure.
isn't it? If you had a young, fit patient, then what this does is reassure you that when they run into oxaliplatin problems, you could back off a bit. I think what would have been perhaps more interesting would be if they'd moved earlier to the maintenance, so 4 cycles of Xelox, then move to maintenance, to an extent a bit like we did with COIN. Mm-hmm. That would have been, I think, a really interesting...
and you might have had a second chance then to go
more oxaliplatin.
Sure. And how about the bearing that some of the people were saying that they should have had an arm where there was just capecitabine with no BEV? And yeah.
It makes for a very big study.
Yeah. And it's a perennial question, isn't it? You know, it's because it's not been done yet in any trials. People have looked at maintenance BEV, they've looked at maintenance Xelox, for what it's worth.
They've looked at maintenance infusion fiber in the studies, didn't they?
Yeah, I think actually, to be fair to Mark, I think it's a valid point that there wasn't a maintenance capecitabine arm. But a maintenance capecitabine arm at 65 milligrams per meter square would be a really interesting thing to have done.
Sure.
Yeah.
Sure. Okay. And so we move on, Andy, to the other maintenance study, which was from the Swiss group. So do you want to talk us through this one?
Yeah, this is confusing in a way, the way they presented it, because they presented it as a non-inferiority trial. So they're saying maintenance bevacizumab is standard, and that they're therefore looking to see whether not giving bevacizumab has a major impact. And in fact, it's a non-inferiority trial, which means to say there was a small difference in their primary endpoint. Whether that's a meaningful difference, I think it's not a meaningful difference. And I think the message is that single-agent bevacizumab is probably not a very good maintenance approach.
And so, Mark, we also mentioned that it was probably the first time we've actually seen an upfront cost analysis presented as in part of the data.
I think this is really interesting. I've been to a few ASCOs now, and I've never seen a cost analysis. And I suspect we're going to see more and more of this as an important part of what we do. We need to know how much things cost.
Sure.
And one imagines several years down the line where this will be almost a standard of what you're analysing. And of course, if this had shown an enormous advantage to the bevacizumab, the cost becomes valid. And so it's an important thing for us to look at.
Where do you think it places the cost between this and the previous study? Because capecitabine is not cheap.
No, but it's not. It's off patent at the moment. It's probably not that much more expensive. There are, going slightly off piste here, There are a number of things in colorectal which we've never done, one including which is a dose-finding study of what dose of bevacizumab we actually need to give. We give doses, it may well be that we can get away with 1 mg. And it's that, again, I suspect they'll never be done, but they're valid things that we should think about in the future.
And again, in terms of kind of UK practice, and in fact, even we think in US practice with all the cost, I mean, do you think this really puts the nail in the coffin of saying that it's a worthwhile strategy or cost-effective strategy of giving maintenance bev? Are we now saying it's just not? one, it doesn't work, and two, it costs too much. Exactly.
So, yeah.
Okay. Okay, so we're going to move on to the EPOC study. So, Mark, do you want to comment on this one, which was presented by John Primrose?
So this is an interesting study. It's been presented probably prematurely because the trial has been stopped by the Data Monitoring Committee because they feel, I assume, that it's past the stopping rules, which effectively means it can never move in the other direction. And that's a problem for us because they're presenting relatively immature data pretty soon after a data monitoring committee said it's time to stop. And so we have to look at all of this data, not with a jaundiced eye, but with an eye that says we're going to get more information and we need to think about that when it comes along.
Sure.
So what this does is slightly turn on its head all our previous suppositions about the value of combination chemotherapy with an epidermal growth factor receptor in wild-type KRAS patients. And what it says is, in fact, this approach in this trial is associated with a poorer progression-free survival. And that differs from other studies effectively looking at liver mets. Not necessarily operable ones, but it differs.
And I think it's clearly saying there isn't an advantage in mainly operable cases, because it is mainly operable cases. Whether it's a disadvantage, we're not so sure. And we haven't got a biological or plausible reason why it should be a disadvantage in this particular group of patients. But it's a very interesting.
Yeah, it's very thought-provoking, and there is a desperate need to look at the information, to have more information to help us come to terms.
And I think they're going to get that because they've got paired tissue samples and they'll be able to do a lot of
I agree. I think I'd hope that kind of by next year ASCO, even if they haven't got all the events of 200, they would have some data from the metastaectomies. Also, certainly there was a discussion about that we need to know in some ways what the post-progression, well, what would the, if they did progress, what chemo they got.
And there are other little interesting bits. There was non-central review of imaging.
Yes.
And I do think there are radiological issues here that would be useful to look at and to see.
Okay.
So there's lots more data. I think what we're saying about the study is really provocative, with a lot of data you'd like to see.
And I think it was very honest of even the presenter who was said this is very disappointing. Well, we better find out why, and so I'm sure they will. Okay, so Andy, we move on to a few more kind of combination chemotherapy trials. This was the TRIBE trial. Can you comment on this one?
Yeah, I mean, I think the triple combination regimen with bevacizumab over the doublet has shown shown a progression-free survival benefit, which of course is its primary endpoint. It clearly is more active. This is a very select group of patients. They were all performance status 0, 1. They were all younger, and how deliverable this is to a general population, I think is called into question. But I think it's got some role, because certainly if you want to shrink tumours to try and get people to operations, or the very young and very fit who want to go for it, that's fine. What we don't know is if you give all 4 drugs, I suppose, up front, do you have a downside? I.e., do you run out of options later on as the relapses come? The overall survival data is immature, but maybe it's got some hints that it's going in the right direction. So, interesting study. If it wasn't so toxic, we'd be jumping up and down and saying this is progress.
I completely agree with Andy. You have to select your patients you want to follow this approach to, and it's going to be young, fit, symptomatic, the possibility of probably a resection of some form. Otherwise, you're going to run into significant toxicity problems with this kind of approach.
And Mark, there was a kind of unplanned subgroup retroanalysis about subgroups, and they kind of pulled out something out about the BRAF mutants. Do you have a general comment on whether that's valid?
It's kind of encouraging if you have a patient who's got a BRAF mutation, this might be a way forward, but it's like all planned analysis. We pull something out of the ether that we need to think about. And again, you want to look at the biology before you start to make too much of a
I don't think
fuss about it.
I don't think you can say this is a new standard for mutation patients. It's interesting.
What is interesting is, for those who remember the previous studies looking at FOLFOXIRI and BEV, is when they got to the phase 3, things like response rates dropped. They were claiming response rates of over 80% before, and they've now gone down.
But that's fine, that happens.
Yeah.
You know, that's real world.
Yeah.
Okay, so Andy, we move on to the FIRE3 study, which provoked a lot of comment as well.
This is a very provocative trial. I mean, the primary endpoint's not met. There's no response benefit for the either arm, for that matter. And then what happens is the survival curves look exactly the same till about 18, 24 months, and then they separate. And we have no idea why that is. And I think there's lots of postulations. You could postulate that there's a different treatment approach going on. You could postulate that the chemo backbone is interacting with something. Maybe there was more operations going on.
This is data that they couldn't provide in real time on the presentation, unfortunately.
And there's all sorts of interesting theories about how deep your response goes and whether that leads to a late change in overall survival. We just don't know, and I think we need a lot of caution about that result. It looks odd, it doesn't make sense, we haven't got an explanation for it.
And even going back to the first primary endpoint, I mean, just comment, that's quite unusual primary endpoint, don't you think?
Yeah, I can see why they did it. I think they were assuming that the wild-type cetuximab treated patients would have a much higher response rate than the same chemo plus bevacizumab, and they haven't. Yeah. And that's very interesting.
I think this kind of twist in the tail in terms of the overall survival is really quite interesting, because actually if you look at the FOLFIRI plus cetuximab or bevacizumab up front, their PFSs are the same as you'd seen in any other trials of these combinations. And then you see something strange happening to a relative minority of patients, and the data wasn't there to explain why this should be, which has led to lots of speculation over coffee and beer. But I would love to see what they got at crossover, what they did. I think that would be really interesting.
And I think until we know that, we won't change our practice. But also, I think it's interesting with the new CDF rules how that might work, because we can give cetuximab at all lines, BEV we can only give at first line. And this study, if it was true, would be pushing us to actually starting with cetuximab first, if you believe this data, correct?
But the problem with that is, of course, you might consider that, but actually that's only up front. That's your first lot of chemotherapy. You don't know what you're doing. Like you have to know what you're doing in all sequences to really get away with that one, I think. Okay. And we can spend months speculating on why this should be.
I don't think it changes what people do, actually. I think you can still do both.
Yeah. I think what people forget, though we're much better managing skin toxicity, cetuximab has a lot of problems, especially as a first-line chemotherapy for patients who
as a palliative
often it's a rash, and it's the rash actually. I think
diarrhea,
it's actually the rash. They don't like having a really bad rash, even though you say it's working.
Yeah, it's an obvious discriminator. You can go into our outpatient clinic and tell all the patients who are on cetuximab.
Sure.
Yeah. So.
So at the end, there were just kind of two kind of biomarker type of trials. One which looked like it was an interesting one because it was looking at a population of BRAF mutant patients who we do desperately need kind of novel therapies. I think the only thing I would say is that of course we do have the Focus 4 study coming through, and we are looking at these kind of combinations for the Focus 4 study. And I think the only other thing from the discussant which was interesting was that it was just a general principle about knowing your target, understanding biology, making sure you've got a biomarker. And clearly in the BRAF study they did, and the reason why the tafasitamab really wasn't, there's a whole discussion, and I like the PARP problem, where we weren't actually sure the MET inhibitor actually inhibited MET. And do you have any other comments on those two trials?
I think they're explorative.
Sure.
I don't see either drug making it to a license from the data we're seeing from these data. But I think, you know, it's the right way to go. You're trying to use more biological information to make better decisions about drug selection.
I think the whole problem, particularly with MET, is actually selecting who are MET over and who are MET under. There's an enormous issue about actually choosing your appropriate definition of your target before you even get started. And I'm kind of with Andy, that it's nice to see attempts to do good biology with an appropriate target. And I suppose it's kind of watch this space and see what we've seen.
I think I would only disagree with you about the kind of licensing. I think, no, in the sense the FDA, I think with the data, which was very early on the BRAF, because they had a sustained complete response for 14 months and very good partial response, they may get a kind of orphan drug status where they're just going to go in there and license it. But we'll have to watch that.
The overall response rate was 11%, and it had one very good response in a sort of slightly abdominal wall, unusual picture.
Unusual picture. Yeah. And it was a single arm. I mean, we'll have to wait for the randomized data. Yeah, sure. Okay. And I think that wraps it up.